add on to a comment that you mentioned, and this is for the junior scientists in the room who aren't exposed to patients. We do this yearly boat cruise, and it's mandatory that everyone on our staff, from our secretary through our director, and everyone in between attend this boat cruise. And it's a 2-hour boat cruise. We're on the rivers of Pittsburgh, and we've done it now for 8 years. And what it has done for our patients is it gives them this one-on-one time. There's an assignment as soon as you get on the boat. I will tell the staff and the faculty, you have to sit at a table with patients, so you can't all sit together. So it's interesting, because then what happens is it breaks down those little barriers. But I tell the patients then, I said, okay, the ground rules are that you have your physician, you have the database manager, you have the scheduler, you have the person doing the research, you have your physician in the lab, or I mean your physician from clinic here with you. You can ask them any questions, and they're not going anywhere because they'd have to jump off board. And so it kind of lightens the time. But what comes back is the patients are so appreciative, but even more importantly, the researchers who are in the lab and don't really have exposure to patients, they'll come back and they'll say to us, you know what, that specimen now is so much more personal because of the people who I met. And what we have found is that we have this support group 8 times a year, and that we have almost equal participation and attendance from our people in our lab and our whole center, as well as patients and their caregivers. So it's really important for you as the scientist not to lose focus on the patients, because your work means so much to them.
I just want to make one. When Luke and I, when we started to discuss this, Luke had spent some time out in California with Talmadge and Hal and Dean at UCSF, and he was very impressed with the support groups and trying to make it an integral component of patient care. And I think it's, you know, it's kind of a whole psychological, social, emotional aspect of diseases. Sometimes it's hard, having been a physician, to deal with it, and it's a very kind of powerful thing for the patients to be able to communicate with one another. I mean, as Kathy said, I mean, you know, and you have people that ski in Colorado with their oxygen, or go out on motorcycles or things of that nature. And it's one thing for a physician to say that, but for the patients to be able to interact and to see that. Again, a lot of number of patients, you know, when they need oxygen, have a little reluctance to take oxygen because they think that somehow that's going to make them progress more quickly. And again, being able to deal with that in a supportive environment, and to hear, from other patients, no, it doesn't make me progress any more quickly, and it enables me to live kind of a much more full life. So, Dolly, do you want to just talk a little bit about our kind of collaborative U.S. and international efforts, and a little bit of the information that's available for any of the physicians that might be interested? This is Dolly Kavitsky. She's our vice president of, I assume everyone knows Dolly. They know her better than they know myself. But
That's okay. I'll just stand. There's no chair. It's fine. So as some of you know, we held a support group leadership workshop here on Saturday. Many of you attended, and I truly appreciate your enthusiasm. We've developed some basic guidelines that welcome all of you to take them. We have them in multiple languages, as well as our patient information guide on pulmonary fibrosis. And I want to stress, pulmonary fibrosis, not IPF. We've broadened the handbook a little bit, and I want to thank those of you in the audience who have participated in the review, the professional review of those booklets. It's really been helpful. So for those of you who are not aware of them, please pick up a copy or go to our website. They're on our website in multiple languages. If you'd like some to take with you, or if you want us to mail them to you, we're happy to do that for your groups as well. But the foundation is here to help you with your support groups. We're hopeful that we can expand the program internationally, and with your help, we will be able to support you in those efforts. So if any of you want to call us, talk to us, or email me, please do so. Contact information is on the table in the registration room. Also, we'll be having our letter of intent period for our research grants come out soon. So those of you who are not familiar with the program, it is international, so anyone can apply for our grants, and we look forward to receiving your application so that we can learn more about your research and make an impact on this disease. So Kathy brings up a point. She's whispering in my ear because I have notes that are not with me. So we have several different kinds of support groups. We have ones that are what we call face-to-face, where people get together in a room. They can be as large and as small as you would like them. They can be 2 people to 200 people, vary in sizes. And we also have what we call our online support groups, and those are available on our website. So if you go to them, there's a support group for patients, and there is a support group for caregivers. You can join either one. I find it helpful to look at what the patients are talking about. These are professionally moderated groups, so we monitor what is being said on these on the online groups so that we don't propagate some terrible miscommunication in the disease. But patients have 24-hour help on those. If they can't get on, they can call somebody. You can translate so that it reaches a number of people regardless as to the language that you speak. So that's also available. We're also looking at what we call our remote support groups, where patients, they may not be technically savvy, so they don't want to do the online support groups. Face-to-face isn't for everybody. Online isn't for everybody, but they may be able to pick up a phone and participate in a conversation with a support group as it transpires. I have many patients in our support group in Colorado that actually do this. They live just a little too far, or it snowed just a little too much, or they know that they're going to hit rush hour, which Kathy brought up on Saturday. That rush hour is a big deal for our patients. They're generally older and not as tolerant to the traffic that many of them have to put up with. And personally, I don't want to be on the road with them either if they're uncomfortable. So.
Thank you, Dolly. Thanks. I think we set the stage for, at least for this topic being on the agenda of this group of people and companies and investigators and basic scientists and clinicians. So I think that this is a starting point. It's important that it has been recognized and in a way formalized. So, yes.
I just have a quick question. And this comes from my experience of working with Kathy and with the folks in Pittsburgh. And I really think that Pittsburgh has set a paradigm for a lot of things that actually could occur between academia, pharmaceutical companies, and advocacy groups. And so I really welcome all of Kathy's ideas. As a matter of fact, in Boston, we're going to start having a golf outing and a lot of the activities that you've thought about. But I wanted to ask a question to pharmaceutical industry and advocacy groups. As you've seen how important it's going to be in the future to have standardized biorepositories. And there's an unmet need in terms of where the money comes from, because the NIH is not going to give us money for that. And I understand the importance of giving grants to educate young investigators, and I also understand the importance of funding good science. But have you both considered the possibility of actually doing competitive grants to fund research registries?
So you're right, and in fact it came up clearly as one of the discussion points, certainly in our group. I imagine it did everywhere else. So two things. Firstly, where individuals, so just speaking from a pharmaceutical perspective, where companies have got their own individual studies that they're funding, I guess there will be some difference in how that data is used and how it is published. I can speak on behalf of GSK, which is that you can't generate any of this data without collaborative research with academics. So for that reason alone, the data will be published. And the second is that we, as a company, have decided that we will publish all our data. And in terms of clinical data, then the regulators demand that we publish it all. So that's sort of one aspect to, I guess, the sharing of information. So then the question about getting access to tissue, so I believe it's vital. I think it's the missing link. I don't think it's going to be the answer, but I think adding to the critical mass of data that we need to support target validation and drug development, it's very helpful if you can generate data in human tissue. So a great believer, needs to be done. IPF it's still a small disease. And I think, we have to recognize that it's still a relatively small disease. So it is challenging, and I'm being frank here, it is challenging for individual pharmaceutical companies to just, throw open their doors in that completely pre-competitive way when the target population is relatively small. I think there are ways around it, in that I think firstly there are things that can only be done pre-competitively, like validating an outcome. I think there are expanding the remit beyond, thinking of IPF, not just IPF, but as pulmonary fibrosis, opens the space. That I think there's more room for maneuver for companies, and that would enable you to get a critical mass of funding. I'm not sure it's a biorepository is the thing that pharma should spend its time doing. So I think we can support and we can work pre-competitively, and we can share our data in other ways. But I think probably you're the clinicians are the people that are deciding to get biopsies, that get those samples. And I think you're the primary, I guess, curators of patient material. We go to clinicians, in academia for it. So I think you guys are the ones that can solve that particular problem. And I think we can certainly help in terms of how biorepository material could be used to help drug development. But I think, on the other side, I think pharmaceutical companies can work together on other aspects of pre-competitive behavior. That's my view, and I'm only representing one view.
I think there are models in other diseases where you kind of form a consortium, and that it could be useful to multiple pharmaceutical companies, that they can get the data that they need. But it could also be done in a collaborative fashion. I think these things are pretty expensive to do, and we've looked at this pretty carefully, what the cost entailed, and I think without the participation of the pharmaceutical industry at this time, and this has worked in other diseases. For example, multiple myeloma has developed a consortium of 3 or 4 pharmaceutical companies, and with their biospecimens, and there's just 2 or 3 new drugs that have been approved as a result of this. So I think if you can get a few companies to buy into this, we can do that. I think that the issue that was brought up yesterday in terms of the standardization, again, I think an organization like this could hopefully come up with a policy statement of, again, like, Pittsburgh and other places, University of Colorado, have ways that they standardize, they collect their biospecimens, and then there was the LTRC, the Lung Tissue Research Consortium, and GWAS and things like that, that there are examples of doing this. And again, we've talked to the people at the NIH, and they don't have the money to do this. However, they're willing to kind of participate from the standpoint of their expertise, organization, and things of that nature. So, but I think that's a critically important point.
Yeah, I'll just give you two little comments regarding this. I think that our community and individual investigators are extremely motivated to generate these repositories. But there's conflict of interest that are more and more separating us from pharmaceutical industry, and it's not coming from us, it's coming from our own, the regulation of our institutions. It's more difficult to create these relationships. It's very awkward for a physician to ask of their patients and communities to actually support some of these activities. So it seems like an ideal situation in which somebody who does not have a direct vested interest like your organization can actually educate patients on how important it is to participate and help create these biorepositories by participating. And at the same time, I think the pharmaceutical industry has a lot to benefit, not only from freezers full of specimens, but actually databases that contain patients with select phenotypes that you can then use as populations for the study. So I think everybody has to gain from this, and I just want to say that as individual investigators, we're all very motivated to do it.
Yeah, and just, I mean, to clarify, it's not that I don't think we should help support it, financially and otherwise. I just think that the drive, and I guess the body, I think, should kick it off. It should be, as you say, it's going to be about, there's logistical aspects to it, as you say, like it costs money to store samples, but I mean, part of it is going to be changing the attitude to getting the samples. And there was Phil, you made a comment in our meeting today, which was, you guys are too risk averse, was the comment, right? About deadly silence fell, but about getting samples, and I think so. I just think as a body, it's the clinicians and the patients that have to drive, what samples, and get together, as you say, in a sort of non-competitive way to share that. And of course, industry should support it because we do stand to gain. I just don't think that industry, maybe I misread the point, but I don't think we can be the drivers of setting up.
Oh, no, absolutely not. I think it's our responsibility as investigators to actually lead this, but our interactions with the pharmaceutical companies and with the community is enhanced by the situation, by the people that are sitting in this panel.
Yeah, I want to raise, Kathy implemented a program at Pittsburgh where they actually obtain autopsy specimens. They communicate with the patients, and within 6 hours of death, and the patients are actually a lot of the patients are very readily want to participate in this. So I think your point is well taken.
Okay, thank you everyone. I think we should close the session here, and I think it was important to make this point.